Good evening, and thank you for joining us for tonight's session on updates in IDH-mutant gliomas, hosted by the Florida Society of Clinical Oncology. We are truly honored to have Dr. Ashley Ghiaseddin with us as our keynote speaker to lead this important discussion. Before we begin, a quick reminder that this program is being recorded for conversion into a podcast and will also be available on the FLASCO YouTube channel. Please note that all attendees will be muted for the duration of the session. We encourage you to submit any questions through the Q&A chat feature located at the bottom of the screen. Dr. Ghiaseddin will do his best to address as many questions as possible, time permitting, at the end of the presentation. Additionally, for those with a professional focus in neuro-oncology, I'd like to highlight FLASCO's Neuro-Oncology Consortium. This working group plays a vital role within our society, and you can learn more by visiting our FLASCO website. Now, without further ado, it is my privilege to introduce Dr. Ashley Ghiaseddin. Dr. Ghiaseddin is a neuro-oncologist and the chief of the Division of Neuro-Oncology at the University of Florida's Department of Neurosurgery. His expertise lies in treating brain cancers, including glioblastoma, utilizing targeted therapies such as chemotherapy, immunotherapy, and precision medicine. Dr. Ghiaseddin earned his undergraduate degree from the University of Notre Dame and completed his medical training at the University of Toledo. He also completed his residency at Indiana University and a neuro-oncology fellowship at Duke University. In his role, Dr. Ghiaseddin works closely with the Preston A. Wells Jr. Center for Brain Tumor Therapy to advance treatment options and improve patient care. His research focuses on immunotherapy and quality of life studies for brain cancer patients. An active member of the Florida Society of Clinical Oncology, Dr. Ghiaseddin serves as the Oncology Captain for Neuro-Oncology and as FLASCO board member. He is also a leader in the American Academy of Neurology's Neuro-Oncology section and has principal investigator roles in several clinical trials. His clinical expertise includes glioblastoma, astrocytoma, oligodendroglioma, and other brain tumors. We're excited to have Dr. Ghiaseddin with us tonight. Dr. Ghiaseddin, the floor is yours.
Thanks so much, Kelly, for the warm introduction, and to FLASCO, as well as everyone who's attending today. When I talked with FLASCO about updates that I wanted to consider, especially for a first webinar, I thought about really what are the recent changes in neuro-oncology that have really made us consider practice-changing treatment for our patients. And I felt it was timely to really give an update on the IDH-mutated gliomas with the recent approval in August of 2024 of vorasidenib, as well as the June 2023 updates at ASCO regarding the Indigo study. I felt this was a great time to really start talking to the community about what updates there are for the IDH-mutated gliomas and how that affects the current treatment paradigm and where we expect to go in the future. These are my disclosures. And I'll just briefly put up the course objectives, goal of identifying existing emerging treatments of IDH-mutated gliomas, understanding the challenges we face in IDH-mutated glioma treatment, and really understanding the role of IDH inhibitors in that treatment. When we think of adult type diffuse gliomas, we're really focusing specifically on today's topic, the astrocytoma IDH-mutating gliomas, the grade 2 through 4, oligodendrogliomas, IDH-mutant 1p19q co-deleted, which can be graded 2 through 3, and not relevant for today's topic, but another type of glioma that many of us deal with are the grade 4 glioblastomas, which are IDH wild type per the new WHO grade classification. What you'll notice is with the WHO grade 2021 classification, there is now a grade 4 IDH mutant astrocytoma. And that's because the IDH mutation was taken out of glioblastoma with the WHO grade classification for 2021. Previously, IDH mutated gliomas could transform to grade 4, and then they were called glioblastoma IDH mutant, but that has now gone to the wayside with a goal to really homogenize the different type of gliomas and understanding that the IDH mutated gliomas are a specific type of glioma different than the glioblastomas, both in the expected response to treatment, as well as the prognostic information for those tumors. The goals of treatment for gliomas are quite simple when we break it down into local and systemic control. Locally, we think of surgery, radiation, and then we start to think about some of the new additions, tumor treating fields for the glioblastoma. And then in recurrence, people think about stereotactic radiosurgery as a potential option specifically for new areas of recurrence that are outside of the original treatment area. And then laser therapy as another option for patients where there is a recurrence that is less than 3 by 3 centimeters and in a region where a biopsy and laser ablation is possible. For systemic control, the bedrock is still chemotherapy, but more and more you start to see targeted therapy, precision medicine as an option for patients where there are mutational markers present that may respond to treatments that may have been available in other cancers. We can now consider for gliomas as well, as long as we know that they're able to penetrate the blood-brain barrier and get enough concentration there to be effective. And then immunotherapy I placed there because although we know for gliomas in particular, immunotherapy hasn't had the success that we see in lung cancer or in melanoma, there still is a lot of excitement in using immunotherapy maybe as a combination approach for these tumors. Why glioma treatment is so difficult is really because there's infiltration of the normal brain tissue. Think of these type of tumors as not being a grape and jello, but more of grains of sand. So you remove what you can see, although we know that there is microscopic tumor cells that are around that area that's been resected. And unfortunately, because of the highly eloquent nature of the brain tissue, we know that we can't just continue to remove tissue for sake of having a better extent of resection. It's just not possible because we know that patients that have significant neurologic deficits after surgery, they don't do well prognostically. So we need to be careful to preserve tissue and really keep people as functional as possible so that they can tolerate the treatments that they may receive. Recurrence, unfortunately, is common for gliomas, as well as transformation to higher grade. And we know that rapid growth can cause symptoms that are concerning for increased intracranial pressure, headaches, nausea, vomiting, cerebral edema. And we talked about the microscopic disease that we really can't capture on imaging. Molecular profiling has really come into vogue and embedded itself within the paradigm of prognosticating and diagnosing these tumors. And the reason is with gliomas, histology can be difficult to differentiate tumors. What molecular profiling can do is reduce the diagnostic inter-observer heterogeneity. You can improve the accuracy of diagnosis and increase the objectivity. We also use it to help us inform the clinical trial determination when we consider patients by improving the speed at which we determine eligibility and our goal to enroll patients that most closely resemble each other, a homogeneous data set that can improve the reproducibility that we would want to see in the real world, so that when there is a drug that we think may have a benefit, we're able to then put this into the real world setting and hopefully have the same type of benefits that we see in the clinical trial arena. And outside of this work, because we know in gliomas we have limited treatment options that we can offer our patients, we need to always be thinking ahead and what options may exist outside of the standard options. In recurrence, outside of a clinical trial, we know that there are many options that are not standard. And if you ask 3 different neuro-oncologists what a treatment option outside of a clinical trial will be, you may get 3 different answers. And that's why identifying molecular alterations within that tumor is very important, because there may be potential targets that you could consider for patients, because we know that the treatment that we currently offer for patients, specifically in recurrence, is not good enough for the majority of patients. So this is a great way to think ahead. I list here several targeted treatment options in gliomas. And the reason is many times people think in neuro-oncology, outside of temozolomide, what options do you really have for patients? And that may be true partly where we don't have the same treatment options that other solid tumors may have. There are molecular alterations that are effectively targeted, and those are things that we really need to be considering for patients when we get next generation sequencing molecular profiling for our patients. The BRAF V600E mutation is not only eligible and beneficial for melanomas, but you can see in gliomas, low-grade gliomas, there has been benefit for those patients who receive BRAF MEK inhibition. NTRK fusions also have been really found to be targetable as well. FGFR mutations, the H3K27 diffuse midline gliomas have now had targets as well. Today, we're going to spend time talking about IDH mutation, but I leave that up there as well for you. And then in children, there are several other options that are available for patients. And you may have heard more recently about the targets for NF1 patients with selumetinib. And I leave that there for you to see. Now, unfortunately, we're having this talk because we want to highlight that since the 1960s, outside of surgery and radiation, the type of systemic therapy options have really been limited. And I can go decade by decade and show you the subtle treatments that have been provided for us to really use for our patients, but it's been few and far between. So since 2005, after temozolomide was really integrated into the standard of care for patients, it's not until 2024 where the FDA approval of vorasidenib for IDH-mutated gliomas in WHO grade 2, ages 12 and older, to really show that now we have something new after all of this time to be beneficial for our patients. So I think that's remarkable in its own setting. But I want to just highlight the targeted therapy options that I showed in the prior slide so that you know that although the changes in our treatment paradigm have been incremental over the decades and maybe slower than we would like, there are options that are available for patients that we are considering. So it's not that it's just, one or two treatments, but really you have to look further into molecular profiling to consider other options for patients. The treatment landscape prior to 2023, when you heard the Indigo results at ASCO for IDH-mutated gliomas, was really what I list in front of you. In oligodendroglioma WHO grade 2, you thought of surgical resection that was followed by observation, or we consider radiation followed by PCV, or temozolomide, depending on your area of practice and patient factors that may lead you to one regimen versus either. In diffuse astrocytoma WHO grade 2, again, you think of the same thing, surgical resection followed by observation versus radiation followed by temozolomide or PCV. And this decision is aided by several factors, which included the resection status as well as age. Now, what I'm alluding to in 2023 was the paper in the New England Journal of Medicine, and this was presented at ASCO in June of 2023, which was the Indigo study, a phase 3 double-blinded randomized study that looked at vorasidenib versus placebo. The glioma IDH1/2 mutant WHO grade 2 status post-resection and patients who did not have an urgent need to receive radiation or chemotherapy. There was a pre-planned interim analysis which showed that vorasidenib had significant improvement in progression-free survival as well as time to next intervention. IDH1/2 hotspot mutations occur in various cancers, such as diffuse gliomas, and the mutation leads to an overproduction of 2-hydroxyglutarate. There can be epigenetic dysregulation and impairment of cellular differentiation and immunosuppressive tumor microenvironment. Vorasidenib, an oral IDH1 and 2 inhibitor, is designed specifically for brain penetrance. And its goal is to reduce the tumor 2-hydroxyglutarate, leading to decreased tumor cell proliferation, an increase in the tumor-infiltrating lymphocytes or TILs, and reverse the IDH1/2 mutation-associated gene expression programs. The INDIGO study enrolled patients who were 12 years of age and older. It looked at IDH1 and 2 mutated grade 2 oligodendrogliomas gliomas or diffuse astrocytomas. The prior intervention was surgical resection only. They wanted to look at measurable non-enhancing disease so that one or more target lesion measured at least greater than 1 by 1 centimeter. The reason for this, they needed to be able to follow something radiographically to really understand was there a benefit or not. And per investigator, the patient was not in need of urgent radiation or chemotherapy. I think this is critical to understand because one thing that people may look at is if you have a patient that has residual tumor, aren't these people that we want to get to our radiation oncologist to treat? And that may be true for many patients. However, we know that there are patients that we follow where we felt as oncologists that this is not the patient that I want to treat with radiation and or chemotherapy at this moment, and I want to follow closely before making that decision. So that's the type of patient that was enrolled into the study. I think that's important to understand as well. Patients were enrolled between January of 2020 and February of 2022. I show you the plot here, and I think the important thing to note from the study was the primary endpoint of progression-free survival per a blinded independent review committee. And what you see is the time to next intervention in the vorasidenib arm was not reached. And in the placebo arm, this was 17.8 months. The treatment emergent adverse events were increased LFTs, liver function transaminases. However, this was only in 6 patients, 3.6% of the VORA group. And 2 patients of the placebo group, they can discontinue treatment due to treatment emergent adverse events. The limitation of the study is we didn't receive the radiographic responses and crossover was allowed. So I know we understand this and something that we need to be mindful of. But you can see here when you look at the progression-free survival, it is remarkable looking at the differences in those curves as they separate. It had a reasonable toxicity profile. And so here again, we talk about treatment interruption due to the treatment emergent adverse events. And you can see slightly higher for the vorasidenib arm, but dose reduction due to this treatment emergent adverse events were 10.8% in the vorasidenib arm compared to 3.1% in the placebo. Now I want to shift to some of the updates that were had at the Society of Neuro-Oncology conference back in November of 2024, which really provided an updated result of this INDIGO study. And this was as of the March 7, 2023 data cutoff on an additional 6 months of data from the INDIGO trial. And updates including the progression-free survival, time to next intervention, safety, additional analyses, and a median follow-up of 20.1 months. The majority of patients receiving vorasidenib remained on treatment. There was one death unrelated to treatment, and no patients were lost to overall survival follow-up. What I'm showing you here is the progression-free survival. This remained twice as high in the VORA arm compared to placebo. After the median follow-up of approximately 20 months, the median progression-free survival in the VORA arm has yet to be reached. The lower range estimate of 22.1 months as compared with 11.4 months in the placebo arm. This difference equates to a 65% reduction in the hazard for disease progression or death in favor of the vorasidenib arm. In addition, what you'll see is the time to next intervention was not estimable in the VORA arm compared to 20.1 months in the placebo arm. So in a summary, we continue to see this significant improvement in the progression-free survival as well as in the time to next intervention that we saw in the initial study results. This persists. Across all of the subgroups, the progression-free survival per the blinded independent review committee favored vorasidenib over placebo. And this is across the ages, in the co-deleted and non-co-deleted tumors. So you see this across astrocytoma and oligodendrogliomas. You saw this in the patients that had less than 1 or equal to prior surgical intervention, or even those that had more than 2 surgical interventions. You saw this in those that had a more recent surgical intervention that resulted in a gross total resection, as well as those that had subtotal resection or biopsies. The only subgroup that crossed that vertical line on the forest plot to suggest no significant effect was maybe in the longest tumor diameter, less than or equal to 2 centimeters. However, there were significant limitations when measuring tumors in 1 dimension. The treatment with VORA, it continues to show efficacy as assessed by both the progression-free survival and time to next intervention with the longer follow-up. I think it's important to know that patients tolerate vorasidenib. The safety profile of vorasidenib was manageable, and it's consistent after 6 months of additional follow-up. There was no new safety signals. I highlight really just the ones that we need to be aware of, and that's fatigue, the increase in LFTs, gamma-glutamyl transferase. We check LFTs every 2 weeks for the first 2 months, then monthly for the first 2 years, and then you may check it every 3 months. So we're not checking labs as often as you see with traditional chemotherapies. This can be very manageable for patients. Again, here, what I want to highlight is looking at the tumor volume decreasing after patients crossed over from placebo to receive vorasidenib. And then another secondary endpoint of tumor growth rate. The tumor volume was reduced with vorasidenib and continued to increase with placebo. Following 6 months of additional follow-up on the INDIGO study, what we see is vorasidenib treatment confirms efficacy with increased progression-free survival and time to next intervention. We don't have new safety concerns. The exploratory endpoint suggests that patients on VORA arm had lower seizure rates compared to the placebo arm, which is important for our neurology colleagues. The vorasidenib reduces the tumor volume, and this is observed even in patients that cross over to vorasidenib. The vorasidenib improved progression-free survival regardless of tumor volume at baseline or pre-treatment tumor growth rate. And I spoke again previously that the FDA approval in August of 2024 gave vorasidenib's indication for astrocytoma IDH mutated WHO grade 2 and oligodendroglioma WHO grade 2 tumors. So now I ask, is there a change in our treatment paradigm? For low-risk grade 2 gliomas that are IDH1/2 mutated, with residual disease, no urgency to start chemotherapy or radiation, in the physician's estimation and talking with the patient, we should be giving vorasidenib. I think that's reasonable to consider for our patients. When there's a gross total resection, no visible disease, I don't think we know the best answer. These are people that we may want to observe versus giving them vorasidenib. And that's something that will play out, I think, in the next couple of years. What do we do for our recurrent patients who have not had IDH inhibitors? Do we give them a monotherapy IDH inhibitor like vorasidenib, or do we need to consider combinatorial approaches? And what do we do for our grade 3 patients? Is there a role for adding an IDH inhibitor up front with chemoradiation? So questions that are still unanswered that we need to answer in the coming months and years. When we think of treatment decisions in a world with IDH inhibitors, I think it's important to note that many patients who have grade 3 IDH mutated astrocytoma or oligodendrogliomas, they are living beyond 10 years. Histologic grading can be subjective in IDH mutant gliomas, which can contribute to the survival overlap between the grades. And I highlight this because I think it's very important when we talk about the overlap, that the overall survival in IDH mutated astrocytomas in grade 2 can be 10.9 years, recent studies, versus 9.3 years in grade 3. So you can see that there is a significant overlap there. The histology is subjective, which implies a sharp cutoff for grades is somewhat artificial. given the inherent continuum of the tumor biology. I think there are some factors that show association with histological grade, which includes the gadolinium enhancement on imaging, as well as the molecular findings. Specifically, we know that CD kinase 2AB homozygous deletions is an established criterion for IDH mutated astrocytoma WHO grade 4, and it's also been shown to have a less favorable prognosis. Even a hemizygous deletion has been associated with a shorter survival. We know that MYC gain associated with risk of gaining post-temozolomide hypermutated phenotype, and all things that need to be considered. There are several that in IDH mutated and 1p19 co-deleted oligodendrogliomas gliomas are not well validated, but can be suggested. And some of these mutations may include the PIK3CA and Notch1, an absence of mutation in TERT, which is quite rare in the oligos, less than 5%, as well as PTEN alterations. And then when we think about the traditional factors that we would discuss with patients, and that was the age cutoffs and other symptoms that they had, the size of the tumors, we need to potentially revisit those. The strict use of 40 years of age to imply high risk, we shouldn't be using that anymore. There's recent available evidence that can show a cutoff in the range of 50 to 60 years is more appropriate when we consider patients for being higher risk. And then for extended resection, when we talk about quantitative postoperative tumor volume, I think we need to consider what that looks like after surgery. At the first diagnosis, when we think of presence of contrast enhancement on MRI, this can be associated with a tumor grade in IDH mutated gliomas, though the finding is neither sensitive or specific. We do think of contrast enhancement, however, to suggest a transformation to a higher grade malignancy. I think up to 50% of grade 2 oligodendrogliomas gliomas, we understand, may show some enhancement, and considerable amount of grade 3 oligos do not. 20 to 50% of the grade in IDH mutated astrocytomas, they may also show some form of enhancement. So things that we need to consider. In addition to the Indigo study, there's clinical trials that are using IDH inhibitors that have shown some activity. IDH1 inhibitors, ivosidenib, olutasidenib, safusidenib, and the IDH1/2 inhibitor vorasidenib, they have all been considered in recurrent tumors, some studies looking at enhancing tumors or grade 3 tumors. And then looking at results like this, I think it's important to remember that real-world data is needed to provide much-needed patient guidance when we're making clinical decisions for these patients. The questions that I had coming out of the conference that we recently had for the Society of Neuro-Oncology was really thinking about treatment guidelines. They often base recommendations from historical series of grade 2-3 gliomas that were both IDH wild type and IDH mutated patients prior to the WHO grade 2021 classification update. So which patients do we know are going to respond best to IDH inhibitors? And I think another concern that people have asked is, do these IDH inhibitors affect tumor biology? Should we be concerned for tumor resistance? And this highlights a need to really understand potential resistant mechanisms. And what do we do at progression for tumors that are treated with IDH inhibitors? Do they continue the IDH inhibitor plus another chemo agent? Or do we switch the current IDH inhibitor for another IDH inhibitor that's available for that patient? I think it's important to understand the unknown implications of delaying radiation and chemotherapy. There are patients where we should not be delaying radiation and chemotherapy. And I would highlight that the original Indigo study, its intent was not to delay radiation and chemotherapy for all patients, but specifically enroll patients where the treating team was going to be observing those patients after their surgery for one reason or another. I think it's important when you look at this data to really consider, do we still watch and wait after a gross total resection for IDH-mutated gliomas? This can be something very difficult to consider, but there are downstream effects. With observation, these patients, they are able to have family planning. They're not tied to a medication, although it has really minimal side effects from what we can see thus far. When you compare it to the toxic chemotherapy agents that we consider for our patients, we need to remember that there is no current really guidance on when to stop this therapy. So, you're going to be on this therapy potentially for years. However, if there's evidence that shows, being on a medication earlier on can lead to better overall survival, that may change how we look at watch and wait methods for patients who have gross total resection. And it's an important thing when we talk about the concept of grains of sand and not really a grape in jello. If these tumors are diffuse and infiltrative, can we honestly say that there is ever a time where we can achieve a gross total resection? The treatment decisions that we consider, we know aren't just based on guidelines or based on meetings, but they're really based on the communication and partnership that we have with our patients. There's family planning decisions, and there's cognitive concerns that we need to consider in patients who are 10 to 15 years out post-radiation. When we think of the young patients, and these are the patients that were ultimately going to be affected by this new treatment paradigm with IDH-mutated gliomas. Although we may have patients that are in their 50s and 60s, ultimately this is a disease that is mainly for patients who are in their 30s and 40s, the early prime working years of their lives, where they're maybe providing for their family, caretakers for others. So it's very important to think about the effects that treatment may have, not just radiation therapy, but even cytotoxic chemotherapy. What do those downstream effects look like? And then in carefully selected patients who have grade 2, 3 IDH-mutated gliomas, I think we need to understand that delaying radiation and chemotherapy may not worsen their outcomes. Close surveillance is necessary. This isn't a patient population where we can really afford to say, have a scan in 12, 18 months. I think with the advent of the new guidelines and treatment options that are provided, we need to rethink the surveillances that we use. And maybe you start with every 2 to 3 months, but you don't go past every 6 months, especially for patients that you're observing. At the first sign of change, we want to consider treatment, whether it's an IDH inhibitor or maybe for the right patient, it's proceeding with chemoradiation. So these are no longer patients that after 5 years, we can say, well, maybe we get a scan every 12 to 18 months. This will need lifelong close follow-up. And that's a change potentially for patients as well. I leave with a picture that really highlights what I talk about with the toxicity that can come from chemoradiation. And this is a patient with an astrocytoma that's IDH mutant grade 3. And 12 years after their initial diagnosis and following the treatment that they received, they have no progression. They're doing, they're off of their therapy. And relatively speaking, from a cancer standpoint, we would say this is a patient that is radiographically stable, no evidence of recurrence. But oftentimes, this is the type of patient that clinically is suffering. They are not able to do their activities of daily living. They are not independent in the home and require constant observation. And although their cancer may be in a hard to say with gliomas remission, but we can say at least stable and no signs of growth, there still are many side effects that we need to consider, and they still require supportive care measures for. So ultimately, by having treatments like this, we really want to afford an opportunity to potentially delay chemoradiation treatments in the right patient population, understanding that it may not be for everyone. And then I'll end with just a study that we have open here at the University of Florida And this is our Adagio study, which is an adoptive cellular therapy platform for the treatment of recurrent oligodendroglioma adult patients. In the world of oligodendrogliomas, the treatment options, we know we've discussed chemo, radiation, and now IDH inhibitors, but clinical trials is something that specifically for this patient population have been few and far between. I spoke to you about the Indigo study, and I know that there are some studies that are coming on board with IDH inhibitors, but really it's rare that you see a study designed specifically for oligodendrogliomas. So I wanted to just share this with the community as a whole, that we have a study that will enroll up to 6 patients, evaluable subjects. So we would have up to 12 patients total because we think about screen failures. And we want to evaluate the feasibility and safety of adoptive cellular therapy that's combined with an IDH1/2 inhibitor in patients who have recurrent or progressive oligodendrogliomas, whether it be WHO grade 2 or WHO grade 3. And after this webinar, the FLASCO team, they have my contact, and please feel free to reach out if you ever have any questions about this study or others in the future. With that, I will end the lecture portion and really open it up to any thoughts and comments. I will thank you for your attention, and I will also say that I realize this is not a one-size-fits-all. And in the world of neuro-oncology, I have learned very quickly that there's not always one right approach, but there are several different approaches that we need to consider. And we do that because we want to identify ways that we can best help our patients and realize that every situation is going to be unique and different. And that's why the work that I do, the work that you do in caring for your patients is so critical, and really the importance of a multidisciplinary team. So I can tell you at our program, these conversations are not done lightly, but they are in consultation with the surgeons, the pathologists, and most importantly, I think in this specific patient population, with our radiation oncologists, right? This is not possible in a vacuum, but it must be done collectively as a team.